All right, well, good afternoon, everyone. Thank you for joining us today. My name is Dr. Gates Colbert, and I will be your moderator today for this burden and management of hyperkalemia and kidney disease in partnership with the American Kidney Fund and sponsored by AstraZeneca. So I'm a nephrologist in Dallas, Texas. I'm the co-program director of our nephrology fellowship here at Baylor University Medical Center with Texas A&M College of Medicine. I'm also in private practice with Kidney and Hypertension Associates of Dallas. And I wear the hats of all nephrologists, do seeing patients in the hospital, have clinic, and then outpatient dialysis as well. So before I introduce today's speaker, we would like to thank our sponsor. Today's webinar has been made possible by a generous support by AstraZeneca, who has several medications in the kidney and heart and hypertension space that are really, really helpful and exciting for patients. This presentation on hyperkalemia is a part of AKF's Beyond Bananas campaign. This campaign has resources on how physicians and providers can talk to their patients about controlling potassium long-term. And for more information, to download resources, please visit kidneyfund.org/beyondbananas. For today's webinar, the audience has been muted, so we will not hear you if you are asking to question or speaking. And we also have the chat disabled. But we welcome your questions at any time, and this can be accomplished. If you have a question, please type it into our Q&A feature on Zoom. We will see your questions and we'll do our best to answer either of them by replying to you directly in the Q&A box or aloud during the final concluding minutes of our presentation today. A few reminders: to request a certificate of attendance for today's webinar, please reach out to professionaleducation@kidneyfund.org. And at the end of today's event, you'll receive a pop-up request for a brief feedback survey. And we appreciate your feedback as we plan additional webinars and resources for healthcare physicians and providers in the future. So now allow me to welcome Dr. Arun Malhotra. Dr. Malhotra is a nephrologist and U.S. Medical Director of CKD and CVRM at AstraZeneca. He received his MBBS from the Armed Forces Medical College of India and completed his residency at King Edward Memorial Hospital at the University of Bombay in India. In addition, Dr. Malhotra completed an internship and residency in internal medicine at Albert Einstein Medical Center and did nephrology fellowship at the University of Pennsylvania. Dr. Malhotra was the Delaware Academy of Medicine president from 2014 to 2016 and was awarded the 2013 Nurse Physician Partner at Christina Care Health System. Dr. Malhotra.
Thank you. Thank you, Dr. Colbert. That was a wonderful introduction, and thanks to the American Kidney Fund for setting this up. I know it's taken them a lot of effort to put this together, but we're delighted to be here today discussing this very interesting disease state that, both of us as nephrologists understand so very well, starting right from our residencies to fellowship, where we are and where we've come in trying to understand the disease state burden, I think a key takeaway for today is going to be to why is it so important. So the learning objectives for this today are that by the end of this webinar, the learner would be able to discuss the prevalence, understand the prevalence and the impact that hyperkalemia has in patients with underlying kidney disease and other comorbidities, and also then apply the latest clinical practice guidelines in the form of KDIGO guidelines and the best practices from consensus conferences for patients at risk for hyperkalemia. Next slide. And then this content clearly has been created by AstraZeneca healthcare professionals for use by healthcare professionals. AstraZeneca is committed to conducting business with the highest standards of integrity and professionalism. And for any information that you have, that you need to access to other AstraZeneca resources, you can certainly visit azmedical.com. And if you have if you see any negative side effects of AstraZeneca prescription drugs, you can call that number 1-800-236-9933 or report it to the FDA. So with that, I think we can jump to the next slide, which kind of starts off our presentation for the day. So thank you once again. Hyperkalemia clearly is a very prevalent condition and is usually caused by an imbalance between potassium intake excretion, I think in between lies some translocation. So there are many factors that impact how the body deals with potassium and thereby what level of potassium we see in the blood, which clearly can be critical as seen by how we define hyperkalemia in the graph in the table on the right. You can see usually we diagnose hyperkalemia with a potassium greater than 5.0, although it could be controversial. You can make it at 5.1, 5.2, but clearly we know that hyperkalemia itself has an impact on many disease states and can be a disruptor of treatment. And I think that's one of the big lessons or takeaways from today is how does it disrupt therapy? Normal kalemia, on the other hand, is normal levels of potassium in the blood at 3.5 to 5, and hypokalemia being below 3.5. Now, hyperkalemia is associated with multiple comorbid disease states, including chronic kidney disease, heart failure, diabetes mellitus, hypertension, and other drugs, agents, the classical ones of which are the RAS inhibitors, the renin, angiotensin, aldosterone system inhibitors. And while often asymptomatic, hyperkalemia does have signs and symptoms that can include muscle weakness, paralysis, heart palpitations, paresthesias, EKG changes, and most of us feel like we need to diagnose it as a blood test and not wait until symptoms occur because it may be too late by then. And in the United States, from data collected in 2014, we clearly know from that data that there are about 3.7 million adults with hyperkalemia in the country. But we know that since then, there have been many other changes. People are living longer. There are also many new drugs in the market that cause hyperkalemia. And my guess is that the prevalence and the incidence of hyperkalemia continues to rise with onset of newer therapies and our focus on life-sustaining therapies like guideline-directed medical therapy in CKD and guideline medical directed therapy in heart failure. So with that, we'll take you to the next slide that looks at hyperkalemia as an independent risk factor for mortality. Now, these are U-shaped curves, as you can see on the graph. This is called a spline regression analysis, and this is adjusted for covariates or variables and looks at the lowest, the curve on this graph is the control group. And if you look at the control group, it basically shows that for different levels of potassium, where does mortality lie? If you look to the right-hand side, you can see that the curves inch upwards for the control group. And clearly the flattened part at the bottom, at the base of this curve, is at 4.0 to 5.0, which is normal serum potassium levels. So the least risk of mortality rise is there when the potassium is between 4 and 5.0. Now, if you add comorbid states, for example, if you look at the next line above it, the diabetes mellitus, which is DM there, it tells you that they have a higher risk of mortality as opposed to the control group based on the same levels of potassium. And this risk continues to climb for heart failure. It's even higher. And what you see in the shaded part there is just the confidence intervals, because that gray part or the shaded part along with the lines is showing you very tight confidence intervals. And then you jump to CKD stage 3 to 5, that mortality risk almost triples for the same level of potassium as the potassium rises with patients with CKD. And if you then go to the topmost line, if you combine all three together, that risk even further increases, which is kind of what our real life scenario for our patients is, because most of the patients today with chronic kidney disease do have underlying diabetes, do have underlying hypertension, do have underlying heart failure. And therefore, the reason why we look at this and say that as the potassium goes up, there is a association with all-cause mortality, and this becoming an independent risk factor, which then takes you to the next slide and showing you how the prevalence is. So you jump to the next slide, you see that hyperkalemia is more common as we age. So in the first graph on the left-hand side, what you see is that as we age, our incidence or prevalence of hyperkalemia continues to rise, rising to its maximum in the age group 85 and above, but clearly beginning to rise very early at 45 to 49, from where it continues to exponentially kind of go up in terms of percentage terms in prevalence. Also associated is the risk, is the stage of CKD, of chronic kidney disease. The worse the kidney function, the higher the incidence of hyperkalemia, as demonstrated by the graph on the lower left-hand side. You look at CKD stage 3, the incidence is only 5%. But when you jump to CKD stage 4, it goes up to 22%. And as you go to CKD stage 5, it's 26% hyperkalemia prevalence in the patients. If you go to dialysis patients, even higher at 43%. And if you take a look at just the heart failure patients with hyperkalemia, the prevalence can be 10%. But when you mix chronic kidney disease to heart failure, that incidence jumps to 50%. So clearly, hyperkalemia is omnipresent amongst different disease states in different percentages, but clearly a player in those arenas where it can actually disrupt the normal life-sustaining therapies, as we see in terms of decrease in progression of kidney failure rates when we're treating with ACE and an ARB, which is angiotensin-converting enzyme inhibitors, and the angiotensin receptor blockers. So clearly, the hyperkalemia is common not only in older patients, but those with serious comorbid conditions, and does play a role as a disruptor of therapy. And that's going to is going to be the theme for today. And if you look at hyperkalemia in terms of other chronic conditions, on the right-hand side, you can see that in patients with chronic kidney disease, patients with hyperkalemia who also had chronic kidney disease, 44.5%. Hyperkalemic patients with diabetes, 50%. So again, making a case showing you how hyperkalemia is so prevalent in patients with different disease states. And the bottom line there is in patients on RASI therapy, hyperkalemia prevalence at 58.3%. And if you again break that down into mineralocorticoid receptor antagonists like spironolactone and plerone, perhaps even higher. So again, these are disease states and drugs associated with hyperkalemia, which then takes us to the next slide, looking at what can we do for hyperkalemia for our patients. And the most common thing that all of us, as even nephrologists or primary care physicians or nurse practitioners or PAs, we all do this, is we all go down and pull out that chart that we have hidden one of the slots in our office, bringing out the high potassium foods and the low potassium foods. And I even had a color-coded piece of paper with all the hyperkalemia, all the foods that had high content of potassium built in or printed in red. So red was bad and green was good. The foods that had low content of hyperkalemia were printed in green. We all tried medical nutrition therapy, but we knew that very often these patients still came back with hyperkalemia. So this slide alludes to that part of our practice experience, that despite dietary counseling, patients with chronic kidney disease and underlying hyperkalemia experience recurrences of hyperkalemic episodes. So when does this occur? This data is from a real-world evidence retrospective observational study, which we call the Revolutionize-1 study. And in this patients, we took patients with CKD stage 3 and 4 with an N equal to 1,503. So pretty large study by nephrology standards. So when you look at these patients and you saw what was the time that it took to their first recurrence, 56% of these patients recurred within 45 days. But as time went through, their episodes, the percentage of patients showing recurrence rose. That the second recurrence was in 58% of that prior cohort. And then 60% of patients of the prior cohort again showed a third recurrence, and the fourth recurrence was in 70% patients. Well, not only that, what you see here is that the time taken to the recurrence is also shortening. If you look at the left-hand side, the first recurrence was at 45 days, the second at 35, third at 29, and then within a month or less than a month, within 27 days, 70% had recurred again. And what this kind of alludes to is the fact that it's not going away despite medical nutritional therapy, which is dietary counseling. So again, pointing out that in a disease state which is not going away, chances are, despite our interventions, despite our best intentions to avoid it by cutting back their foods that are rich in potassium, we might be able to avoid. Some are doing it, but most are coming back with the recurrences. So that is from the Revolutionize-1 data. And I think even if you look at the data in a different way, we also saw that greater than 50% of the initial cohort will recur in 6 months. So just a fact of life. It happens in underlying patients with underlying diseases. Again, just to clarify, these are patients with chronic disease states. In acute states, it could be different, but the kidney disease is not going away. It's actually going to get worse with time. Hyperkalemia follows in the same pattern. So let's go to the next slide and take a look as to how that can impact patients in total costs. So we looked at the burden of what this hyperkalemia can impose on the patient, society, payer, and everybody involved in this whole mix. When you look at ER visit rates, 72% higher rates of visit in these patients with hyperkalemia. You look at the rate of admissions or readmissions. These guys have twice the rate of inpatient admissions, twice a higher average length of stay, accumulating $9,000 more in inpatient costs. Next box shows you an approximately 43% higher average outpatient visits, again accumulating higher costs. In turn, net accumulating a cost of about $31,844 versus a cost of $15 for the non-hyperkalemic patients in total 1 year healthcare costs. So kind of almost bringing out the fact that in these patients, the costs kind of do jump up substantially, driven by the underlying disease state and hyperkalemia. So let's go to the next slide. Again, tackling similar issue that hyperkalemia is a barrier to maximum RASI dosing, which is life-sustaining or disease-prolonging, delaying dialysis, delaying the progression of CKD, delaying underlying or controlling their underlying heart failure rates. And we know that, in chronic kidney disease, the patients actually are not going to die of their chronic kidney disease, but their risk of cardiovascular mortality is much higher. And that is what scares us about kidney disease. It's not that the dialysis risk, which can be substantial, but more than that is their risk of a cardiac event. So when you look at the data, in 1 in 3 patients on RASI therapy who've had more than or equal to one hyperkalemic event during a median follow-up of 3.4 years, that data showed that if you down titrate RASI therapy, with mild hyperkalemia, or that 30% patients were needed to down titrate the therapy despite mild hyperkalemia, and that 47% needed to down titrate therapy with moderate to severe hyperkalemia. And this is data again from Epstein's publication, which kind of then looked at what was the mortality rates, led to almost a doubling of mortality for patients with CKD stage 3 to 4 when their RASI therapy, whether it was an ACE inhibitor, an angiotensin receptor blocker, or other classes of RASi, which included ARNIs and the MRAs. When you looked at that, you saw that mortality doubled in patients who had to cut back or discontinue their RASi therapy. And then the next slide takes you to the fact that if you look at the guidelines, because we're now coming into the guidelines arena, and most of us do refer to guidelines sometimes in states where we're confused as to what to do, because we all have had our own ways of a knee-jerk reaction. And I look back at my own practice several years ago where I would cut back the RASi therapy because of the fear or because of ongoing hyperkalemia, or not give RASi therapy because of the perceived fear of hyperkalemia, without realizing that these therapies were life-sustaining therapies, formed the pillars of treatment for CKD, heart failure, diabetes plus hypertension. So in those disease states, we know that guideline recommended therapy. The guidelines recommended that ACE inhibitor and angiotensin receptor blockers be optimized. But when we look at what are the patients getting, despite 40, almost 50 years of ACE inhibitors being on the market since the 1980s, we only see ACE inhibitor and angiotensin receptor blocker used in patients with CKD at around 50%, less than 50%, 49 to be exact. And then if you look at in those patients who are they actually getting the labeled dose? Because we all used lisinopril, a drop of lisinopril, 5 milligrams, a drop of ramipril, 2.5 milligrams. We all use these generic drugs at very low doses just to check off that box that says they are on the guideline recommended therapy. But when you look at in this cohort as to how many patients are actually getting the right dose, 25% of patients get the right dose of therapy, and the rest are actually getting suboptimal or none. So I think it's very important to realize that these are life-sustaining therapies and that they are important to continue in the patients. And if hyperkalemia becomes the disruptor, we have tools in our front pocket and effective tools today that help us continue or maintain them or optimize them or maximize them on these life-sustaining therapies. Takes us to the next slide in terms of guidelines, which emphasize that ACE inhibitors and angiotensin receptor blockers, optimization, and hyperkalemia management before we think of discontinuing or down titrating these agents. So information from not only the 2024 KDIGO, and KDIGO stands for Kidney Disease International, Kidney Disease International Global Outcomes, 2024 guideline, which talks about the management of CKD, and the similar guidelines were there in 2022, and all of these have kind of followed the similar recommendation or suggestion saying optimize the ACE inhibitor or angiotensin receptor blocker to the highest tolerated dose and monitor the patient for hyperkalemia at initiation of these agents and subsequently as well. And if we see the hyperkalemia come on in some of these patients, we need to enable the ability to continue with ACE and ARB therapy. And only after all of these measures have failed that our knee-jerk reaction should be to reduce or discontinue ACE. So you got to try a lot of things before we cut back on the ACE and ARB or discontinue them. And I actually took a long time to learn this lesson, which came to me not from my regular my cohort of cardiology friends, but from a very young heart failure specialist who actually gave me a call to saying, "Hey doc, what are you doing? Why are you discontinuing this patient's ACE inhibitor? Why are you discontinuing the angiotensin receptor blocker?" And I kind of recognize that there's more to this story. And that's when we realize that the data is very powerful about that, the fact that when you cut back patients' ACEs, ARBs, or guideline-directed medical therapy for heart failure, for CKD, it's better to try everything, including the diuretics, the diet, the drugs that may be causing it, and obviously using whatever's a binder in our toolkit to help enable ongoing or continuing these guideline-directed medical therapies. And only when measures have failed to say we need to cut back because we've tried everything. Takes us to the next slide again, on the same theme with guidelines, showing you that the KDIGO guidelines do have a nice little graph or a flow sheet that discusses this whole issue about initiating ACE inhibitors or an angiotensin receptor blockers. Clearly, we know that we don't use these two agents together from the on-target study, but that once you initiate an ACE or an ARB, you monitor serum potassium and creatinine within about 2 to 4 weeks, depending on clinician's preference and the underlying comorbid states. And then if you see hyperkalemia, as can be seen in the pink color there, you need to go back and review concurrent drugs, monitor the dietary potassium. We talked about that from Revolutionize 1 about how the dietary cake can make an impact, but most of the times does show recurrence, and then begin to consider what else you have in your front pocket in the form of diuretics, sodium bicarbonate, or a potassium binder. And we now know that there's enough in the market that in terms of binders that you have a good choice to make at. And if you can bring on the binder, a potassium binder, clearly you will enable one of the pillars of that guideline-directed medical therapy. And if that fails, then you reduce or stop the ACE inhibitor or the angiotensin receptor blocker if those mitigation strategies prove to be ineffective. That was the diuretics, the binder, the looking at the patient's drugs, and looking and also with sodium bicarbonate. So you have multiple options, but clearly the other options may play a role in terms of changing other dynamics in terms of electrolytes, and therefore one of the safest options becomes a K binder. And I think it's good to equip yourself with the knowledge of how K binders work and impact or enable enable the continuation of RASI therapy slash guideline directed medical therapy. So if you look at the right side here, actions to hyperkalemia management, we already addressed that. The first line is to address the correctable factors, looking at non-RASI medications such as non-steroidals that a lot of patients take surreptitiously or as a prescription from their primary MD or from their rheumatologist or from somebody else who's seen them but did not know that they have underlying CKD. So non-steroidals impact both creatinine and the potassium. The same way trimethoprim plus sulfamethoxidol does, and often patients get a short course of that therapy with trimethoprim, sulfamethoxidol, also commonly known as Bactrim therapy, and other agents as well. And sometimes they are using to be healthy salt substitutes, low salt or no salt or new salt. And there's multiple names to these salt substitutes, which are basically nothing but a substitute of potassium instead of sodium chloride to make it a salt substitute. And so getting a good history, sometimes these patients are on exotic supplements. And to me, the one that always stands out is noni juice from a patient who was taking noni juice after having come back from a trip to the Caribbean or somewhere down south, and did not tell me initially, but since the persistence of hyperkalemia, when we dug deeper, we found that he was on a supplement that had elevated amounts of potassium in it. So clearly getting a good history and addressing correctable factors as first line. Second line is utilizing medications, appropriate use of diuretics, keep being mindful of the fact that you don't drive them into hypokalemia or drive their creatinines higher or dehydrate them, and optimizing serum bicarbonate levels, and utilizing licensed potassium exchange binders, potassium exchange resins, polymers, powders, binders as a tool to correct hyperkalemia. And the last resort really should be to reduce the dose or discontinue the RASI therapy or the MRA therapy in these patients. So the next slide alludes again to how they have kind of sequentially gone through with these guideline recommendations. So the KDIGO 2024 clinical practice guideline for the evaluation and management of CKD, which is chronic kidney disease, does say that angiotensin converting enzyme inhibitors or angiotensin receptor blockers should be administered using the highest approved dose that is tolerated by this patient to achieve the benefits described in whatever study they were alluding to, because the proven benefits were achieved in the trials using those doses, which is what I meant when I said lisinopril at 5 milligrams was not the dose it was tried at, but I often see patients walk in with 5 to 10 milligrams of lisinopril as their standard ACE inhibitor therapy. I often see patients on losartan, which is an angiotensin receptor blocker, walking in at 25 milligrams of losartan. And I'm sure Dr. Colbert also sees this all the time. And that's because, again, we want to check that box off, but not take the risk of provoking that hyperkalemia or are averse to the hyperkalemia, or even the risk of, sometimes it's the risk of hypotension, sometimes it's the risk of elevated creatinine. So we as nephrologists do juggle a lot of these together, but clearly need to recognize that if the issue is hyperkalemia, we have a good tool now to prevent it and continue with ongoing GDMT, which is guideline-directed medical therapy. So let's go to the next slide, which talks about monitoring these patients for hyperkalemia once you are initiating and continuing with CKD and optimizing or increasing the dose in a step-ladder fashion. The guideline states that changes in blood pressure, which we just alluded to, serum creatinine, which is rising creatinine, or elevated potassium, for elevated potassium, we should be checking their blood work about 2 to 4 weeks after initiation or increase in the dose of these agents, depending on the baseline GFR. The worse the disease, the worse the GFR, the quicker you want to have them return back to see you, because sometimes they are very quick to see the effects of that increase in the dose of the ACE inhibitor or angiotensin receptor blocker, and therefore you not want to monitor them very closely. So if it's a CKD stage 5 patient, I would even say check it in a week. If it's a CKD stage 3 patient, I'd say you could check it in 4 weeks. So again, depending on the underlying comorbidities, as a clinician, we pick the time we should the interval that we need to give the patient to see the response to this change in therapy. And then the last part of the guideline, I think, will state, let's go to the next one. Next slide. States that this can be managed, hyperkalemia, if it occurs, can be managed with potassium lowering agents. And this management of hyperkalemia does enable us, or may enable us, to continue with guideline recommended ACE inhibitor or angiotensin receptor blocker therapy. The guideline does give you some leeway here. Hyperkalemia associated with the use of an ACE and ARB can be managed with multiple measures to reduce serum potassium levels rather than cutting back or discontinuing the ACE or ARB. And these include review the concurrent drugs, moderate the dietary intake, consider diuretics, increase in diuretics, the right class of diuretics, thinking about sodium bicarbonate therapy, and obviously thinking about a potassium binder as an enabler to help with continuing these patients or helping them maximize their ACE inhibitor therapy to achieve the best benefits that the trials for these ACE inhibitors and angiotensin receptor blockers showed in outcomes. So let's go to the next slide. And then this last point is basically, again, something that we've made, that, consider reducing the dose or discontinuing the ARB or ACE in the setting of either symptomatic hypotension. Clearly, the patient is falling over. You really know that you've tried to cut back the other agents. So many times we as nephrologists cut back a beta blocker, we'll cut back the thiazide, or we'll cut back the calcium channel blocker while bringing these agents on, because we know the benefits of these agents on their disease states. And while doing that, if that doesn't help and the patient continues to have symptomatic hypotension, I think it's time to cut back. I think it's one of the crucial things as a physician, as healthcare providers, for all of us to understand, is to know when to step back, when to call it a day. It's clearly, if patients already had a fall, symptomatic hypotension, orthostasis, you need to look at decreasing the dose of other medications, but also understand that there will be a time where you say you can't do any more and you need to cut back the ACE or ARB, right? So despite medical treatment, that'll occur not only just because of hypotension, that'll occur also because their creatinines jump more than 30%, or the potassium is not controllable despite all that you've already done, including utilize a potassium binder. So next slide. So this was the consensus count. So we've been through the KDIGO guidelines in terms of the recommendation, when to start, how to do it, how to up-titrate, how to monitor, and what are the agents at your disposal, what you carry as your toolkit to help prevent hyperkalemia and continue them on life-sustaining therapy. But here is the International Delphi Consensus Statement, and these are selected expert recommendations. This came out of a recommendation developed by a steering committee of nephrologists and cardiologists across the world. When I say across the world, I'd say Europe and North America, who developed a series of questionnaires on hyperkalemia management, and then ran it through about 250 cardiologists and 250 nephrologists, and looked at where they could come to a consensus. And these selected consensus recommendations were then published. And in terms of hyperkalemia, they said that it should be recognized as a predictable, treatable, and manageable side effect. So just say that this is prevalent, that it is there. However, it's nothing to worry about. You want to go ahead and treat it. You want to treat it appropriately, and understanding the sense of urgency of treatment, but clearly manageable as a side effect of RASI therapy in patients with a history or at high risk of hyperkalemia. And that RASI use should not be de-escalated or discontinued due to hyperkalemia. unless an alternative measure of hyperkalemia management have been optimized. And we discussed that too, right? And then at the end, they did point out the toolkit, which is novel potassium binders, which should be the preferred agent to manage hyperkalemia, and that managing their hyperkalemia can enable. And most of the times, we could say it's a class 1A recommendation in terms of these pillars that hold that are there for in GDMT for CKD and for heart failure. So they can enable those class 1A recommendations in terms of the RASI treatment, and that stands as class 1A in both for CKD and for heart failure. And to do that, often you'll have to bring on a novel potassium binder to help continue with the RASI therapy that these patients so very much need. Is almost at times called life-sustaining therapy or disease delaying therapy. So with that, let's come back to summarize what I've spoken about this afternoon to all of you, which is, next slide, please, the burden of hyperkalemia, which is, we already talked about the fact that in 2014, 3.7 million adults had hyperkalemia, and clearly the disease state is here to stay. We're only going to see that go up because of people living longer with the disease state, because the disease state being managed more in the end stage, much better management of end stage disease states, and also because of the onslaught of newer medications that are now being utilized that are important to manage these disease states, but do have as a side effect hyperkalemia, which sometimes precludes their utilization, but should not be the case, because we should know that hyperkalemia is manageable and easily treatable, that there are tools, that there are now acceptable and efficacious and safe potassium binders that can be utilized in these patients so that they can continue with their life-sustaining therapy. Hyperkalemia is often associated with multiple comorbidities, including chronic kidney disease, heart failure, diabetes mellitus, hypertension, and RASI therapy. And we also looked at the U-shaped curves, talking about the increased risk of mortality from that data that we looked at from, I think it was Collins data, but those U-shaped curves for how the mortality increases as each comorbidity is added. That U-shaped curve that we discussed right at the beginning of this presentation. Patients with hyperkalemia and chronic kidney disease will experience recurrent hyperkalemic episodes despite our best intervention with dietary counseling, despite looking into their diets, sometimes even sending to a dietitian, and sometimes even asking them to bring in what they're taking over the counter. Just bring your whole drug back here. I want to see what you're doing, and looking at what supplements they're taking. So that's the burden of hyperkalemia. And then we also recognize that RASI therapy increased the frequency and severity of hyperkalemia, leading to discontinuation or suboptimal dosing of these agents that are highly recommended, are class 1A indication in guideline-directed medical therapy. So often taking away the benefits from the patients in terms of their survival benefit or their morbidity benefit, and that RASI should not be discontinued or decreased, but we should bring on the tools to kind of help enable RASI therapy to be continued. Managing hyperkalemia can certainly help enable guideline-directed RASI therapy and therefore improve outcomes. And that was, I think, the crux of this talk today, to understand that hyperkalemia is not just a number, that it has a tremendous burden in disease states, in morbidity, in mortality, and that optimizing potassium management can lead to better outcomes in patients' lives. So with that, I'm going to take a step back and hand it back over to Dr. Colbert to see if we have any questions at this time. I know I've spoken continuously. Hopefully didn't bore anybody. Hopefully I still have your attention. And I'm happy to answer questions. And I'm happy to have Dr. Gates as well chime in, because he is a acclaimed nephrologist at Baylor. I'd like to hear his inputs as well. So Dr. Gates, Dr. Colbert, over to you.
Yes, thank you, sir. That was a great presentation, great overview, Dr. Malhotra. hyperkalemia, kind of the landscape that we're seeing right now, at least in the United States, and what our guidelines are saying about this and how we should treat this in a different way. You know, every nephrologist practicing now, and even cardiologists and primary care, they're seeing hyperkalemia, and how we approach this is very different than we have done previously. We have a lot more tools and we have a lot more knowledge about how to react to these situations and how we can make the situation better for the patient without reducing the therapy that we started from the beginning of their diagnosis, or when we feel like we can make a big difference for the patient. I wanted to ask you a question. You have a lot of experience as a practicing nephrologist. Do you feel like hyperkalemia and the burden of hyperkalemia is increasing over time, or do you feel like if it's staying about the same and we're just diagnosing it better? How do you feel about kind of the landscape of chronic hyperkalemia?
Right. That's an excellent question because I think that both points you're making are valid. I think that we have more people being diagnosed and being caught because of the ease of testing. So it's easy to test for. It's a number, it comes right back. But I also think that it's increasing because of the importance that heart failure physicians are placing on the utilization of the four pillars of heart failure therapy. And within our area with nephrology, the importance of using an ACE and ARB because they're generic and they're cheap and we want to optimize them. That's the only benefit we could give them before the SGLT2 inhibitors came in. So in trying to optimize what's generic, because you know that SGLT2 inhibitors are still not generic, but they are being utilized. Nephrologists highly believe in that class. But when they look at the ACEs ARBs, it's a cheap drug, you get a good benefit, you want to optimize it, so there's a push there. Heart failure side, they're pushing that. In the CKD side, we're also now looking at non-steroidal MRAs as, and there's an onslaught of those coming. Right now, there's only one non-steroidal MRA, but I think we'll have about 3 in the next 3 years. Similarly, new classes are emerging. For example, the aldosterone synthase inhibitors, notwithstanding the fact that there will be modulators of mineralocorticoid receptors. And even though they have a very low incidence of hyperkalemia, they do have some incidence of hyperkalemia. So I think the field is expanding. And again, we see that also with transplants. I mean, I think the heart failure transplants, the kidney transplant, when we see transplanted patients, because of their long-term use of calcineurin inhibitors like tacrolimus and cyclosporin, we see ongoing hyperkalemia, which is again treated with a binder, not by taking their calcineurin inhibitor away. So again, I think that we are seeing the field expand. There is going to be more hyperkalemia. I think cardiologists will need to get very comfortable treating hyperkalemia. Primary care will need to get very comfortable treating hyperkalemia. And that's because of the fact it takes so long to get a nephrologist on board. I know that when I used to get a consult, if the physician is not calling me on the phone, I don't have the time to see the patient, and I hope that they will treat it because I'm booked for 6 months. And with that, I think there's an increased utilization of ED and the healthcare resources from the hospitalization side. So again, as a community of physicians, as a community of healthcare providers, all of us need to be very comfortable treating hyperkalemia, not only in an episodic way, but also understanding that it's chronic and that we need to think about it long term. Otherwise, the patients are going to continue to hit the ER, as I made the point about recurrence with just dietary and nutritional counseling. It's not going away. It's just gone away for maybe a week or two, but it's coming back soon. And that might be on a Friday or a Saturday when one of your colleagues or I'm on call and we're saying, who was the nephrologist and outpatient who's treating this guy who left this potassium untreated? Because now I have to call somebody in to do something dramatic about treating this hyperkalemia, which could be putting a line in and having him dialyzed. But again, I think that the tools are improved now. Clearly, the newer agents work very effectively, much faster, start working the small intestine. So we can, again, we have the beautiful tools now, and having them at our beck and call helps make our lives and the lives of other healthcare providers much easier.
Yeah, absolutely. And a slide and a point that you made that I feel like is important, that happens in real life, is we underdose ACE inhibitors and ARBs significantly, still in the United States. A lot of people want to hit the checkbox of, well, I put them on ACE inhibitor, lisinopril 2.5 or 5 milligrams once a day, or maybe this patient has a lot of proteinuria and they put them on losartan 25 and want to call it a victory. But the studies that we have that show that these ACE and ARBs work well in these patients with CKD, proteinuria progression, diabetes worsening of their CKD, they really used higher doses for all of the ACE and ARBs that were studied. So we need to try to ramp those up as the patient tolerates. I think that's an important part because we need to take in blood pressure and maybe a change in their creatinine or GFR. And when this happens, because I'm aggressive myself with my clinic patients and ramping up their ACE or ARBs, if we see a hyperkalemia or we see a creatinine that bumps up, we want to make sure that our patients are aware that they haven't developed an allergy to the medicine. We don't want them to get worried. They say, oh, my potassium went up to 5.2, so I must be allergic to lisinopril and I shouldn't be on it anymore. Because I've had patients say that. They say, well, I have an ACE inhibitor allergy. And I ask, well, what is that? What is the allergy? Like, oh, it made my kidneys fail or it made my potassium go high. Well, that can something that we can work around and manage. And that's not the same as an angioedema or some sort of anaphylactic reaction, which is much more serious and something we need to take seriously. So given the tools that you described and really just discussion of history and what other medications the patient's taking, we really can find a way for these patients to get on the maximal tolerated dose of an ACE or ARB, and try to really get those benefits of lowering proteinuria, monitoring and moderating their blood pressure, which is going to, as an end goal of prevent CKD progression. And now we even have more and more guidelines saying we need to add on an MRA for proteinuria reduction, for hypertension control in specific patients. And so we know that combined ACE or ARB with an MRA, hyperkalemia can become a risk factor in some patients. But just because we have a high potassium does not mean that either of those drugs should not be combined, or that we have to pick a winner of one or the other.
True, very true. I think that as you look into the number of guidelines, because I know sometimes we're confused. I used to look forward to the hypertension guidelines all the time because one society, the geriatric society, would recommend one thing, the AAFP would recommend another, and then cardiology recommendations were different in terms of that number. They often became confusing, but the one thing that's common amongst these guidelines is this whole issue about the pillars for CKD, that everybody accepts that yes, you can reduce the progression of CKD. Everybody accepts the heart failure, whether it's the AHA, ACC, HFSA, or the ESC guidelines, wherever you or whoever you believe in. They're common, almost in unison, saying, please maximize these drugs because that's what's going to lead to better outcomes. Whereas my knee-jerk reaction when I was a much younger nephrologist was to just stop these agents and just be very happy with my good creatinine that I was able to achieve, not realizing that overall I've actually harmed this patient by discontinuing their ACE or ARB or guideline-directed medical therapy. So I think that impact, or how we looked at it in today's seminar, by looking at the data that came out from Epstein's data, there's even a Kaiser study. There's multiple studies now that show the benefits of continuing the ACEs, the ARBs, the GDMT in these patients while treating their hyperkalemia with whatever tool you want to deploy. And there's now multiple tools, and you can make that choice, but do not give up till you've tried every one of them before you kind of cut back their dose or discontinue it.
Sure, absolutely. And we have a few questions that have come in, and one question that I'd like to ask you is about the Beyond Bananas campaign from the American Kidney Fund. So can you speak a little bit more about the importance of nutrition and how healthcare providers can provide our patient with diet changes to manage long-term potassium?
Right. And we did this all the time. I think we all kept a very a ready reckoner, a very handy sheet right by in my office, both of my offices, because I used to travel between offices. I would keep that sheet very handy. And I think you probably do the same thing. We all have these little handouts for our patients when they ask for it, the handout about the high potassium foods that they need to avoid. And then another, whether it's on the back side of that same sheet, about the low potassium foods that they need to prefer, that are preferred. And therefore, when you looked at those, often what drove me to ask myself that question, is it going to work, was the fact that this patient was already on a diabetic diet, a cardiac diet, a stone prevention diet, and now I'm giving him a hyperkalemia diet. And then the guy would be totally confused, saying, do you want me to eat anything here? So while I totally understand that if it's just the hyperkalemia sheet, it's easy, but many of our patients have underlying comorbidities. For example, they already have underlying cardiovascular disease, so they've already been told for a cardiac diet. Most of them have diabetes, they're already on a diabetic diet. It's very hard as a practicing physician to have the time in that 20-minute slot when you see the patient to say, hey, dump that cardiac diet or dump that diet, just stick with the hyperkalemia diet. I never was able to do that. I don't think it was the right thing to do. So to try and make things easier, I would often ask myself, is it easier for me to just go bite the bullet and get them on a binder? Because if they're on so many pieces of paper that they need to look at which food is which one, and often what I was trying to tell them not to take was preferred on the other diet, was something the other diet was telling them to eat. So now which one trumped which one? So dietary was a tough game. It was simple when it was just plain simple hyperkalemia, but it became very complicated when other comorbidities snuck in along with hyperkalemia. I want to hear what your experience has been with dietary management.
Yeah, so I always try to pinpoint in their history, is there one food that you really have been maybe overdosing yourself with? There's a
Yeah,
lot of people that want to have a banana every morning for breakfast.
right.
Or here in Texas, we love our avocados and guacamole. And so there's some people that maybe eat more than their kidneys can handle at this point. So, I'm not a believer in banning any foods. I think that patients will kind of write you off and you lose some of the trust if you ban foods.
Right.
So I always talk about doing moderation and just thinking about how we can incorporate other foods. But
Yeah.
then I've also anecdotally had a lot of success with the oral potassium binders being able to modify diets. And I know that they are not on label for that, but we do have some good editorials that have been produced, specifically Dr. Palmer and
Beth Palmer.
Clegg have
Yes.
written a paper about it. But we have found that using oral potassium binders in our hyperkalemia patients, if they achieve good control through lab checks, sometimes we can incorporate more healthy foods back into their diet that may have high potassium content. And patients love that because they usually miss these foods, and we're improving their nutritional status because we're usually taking place of a sodium bound food or a sodium containing food. So I found that successful, but you do have to be vigilant about checking on that.
Yep.
But I always ask patients about other medications they may be taking that could have some interaction. Sometimes it's just a temporary issue. They may have sprained an ankle or injury and they've been on a higher dose of NSAIDs than usual. That could be, problematic for a temporary standpoint. But, I really, as you mentioned in one of the slides and spoke about, is taking a good history about what's going on with the patient really can go a long way to managing their hyperkalemia and keeping them on the guideline medications we wanted to do from the start.
Yeah, no, I totally agree with everything you said, including, asking a patient who said, I cannot live without bananas, asking if you could go every other day, and then making a plea for, well, how about having 1/4 and wasting the other 3/4 or saving it for another day? Or, the guy who told me that I'd rather die than not eat my mangoes. I mean, really, are you going to do that? He said, yeah, I'd rather die. I'm not going to. So I had to, but he just said, doc, I'm 84. I'm not going to give up my mangoes. With mango season, I'm going all out. I don't care what your potassium is. So here I was putting him on a binder during the season, well recognizing that he'll do it off season as well. So maybe a change in dose, but monitoring him for titration. So titrating the dose and meeting him on a 3 monthly basis. And then there's certain ethnicities that live a life on lentils. Lentil is a stable food. They're not going to give up their lentils. They're no matter what you do. You can say who cooks at home. Bring in your wife next time. Let me give her the urgency. The wife says, I'm not changing this. I've done this for 50 years. This is what my kids eat. This is what I cook, and we're not changing the lentils. He can, if he doesn't want to eat, he doesn't want. But then you run the risk of then going into a malnutrition state, or taking away the quality of life for these people who already run through their life pretty well and trying to take away that quality almost breaks your heart. So again, there's these cases that have helped me learn that yes, it's sometimes many times it's not about dietary, it's their way of living. You're really trying to change their way of life, and it's not going to happen.
Yeah, fully agree. And we have so many more resources now than we've had in the past. I know we've had the newer oral potassium binders have been out for 8 years now and counting. So there's been, millions of people who've been on the oral potassium binders, and we really can have some positive impacts for our patients in so many ways.
Yes,
Um,
absolutely.
so uh, we are going to move on to our next slide as we kind of close out this session. So for more information on the AKF Beyond Bananas, please visit kidneyfund.org/beyondbananas. And if there are any topics you're interested to support your patient care, you can share it with us at professionaleducation@kidneyfund.org. I will want to thank Dr. Malhotra for joining us today to discuss this burden of management of hyperkalemia. Thank you again to AstraZeneca for their support of this session. And Dr. Malhotra, I'll see if you have any closing remarks, closing discussion.
Thank you, Dr. Colbert, for hosting this. This was wonderful, very nicely done. I would like to thank the AKF, especially Maya, Sanford, Riley, and Gemetra for their involvement and their contribution. Truly appreciated. I think we've both enjoyed doing this together, and hopefully we can do something like this again in the near future, but truly very nicely set up. And thank you for taking the time out of your busy day as a practicing nephrologist. I know how hard it is when you're on service for you to take this time out and give it to the community. So thanks for your contribution, and thank you for all that you do, Dr. Colbert.
Thank you. Everyone have a wonderful day.